Hi, everyone. My name's Natalie Hoffman, and welcome to the Scholarly Scroll. Today, me and other mental health professionals are going to be talking to you about alcohol use disorder. So, I'm going to start off by talking about some essential facts and tools that are going to be important for mental health professionals when working with someone with substance abuse. Um, and alcohol disorder. So some of the things to be aware of are, the documentation of substance use. So if a client comes in for assessment and this leads into denial also in the client history, they might be in denial that they have a substance use problem. And you want documentation like, were they ever in the hospital for it? Were they ever in any groups? Like, were they ever, reported that their family was worried about it, stuff like that. You want that documentation. One of the biggest things, again, the denial. They're probably going to be in denial because some people think, well, I'm only, drinking heavily on the weekends, but then they're not able to function during the week. So we want to know all like along with their history, like I said, those past substance abuse programs, their criminal background, if they've ever been in trouble for like substance use or anything else, and their medical background, if substance use has ever caused them to have medical issues, or even the medications that they're on, and if they've ever had other treatment options. So with that, we go into our treatment options and some of our treatment options for substance abuse, which we will get in later during the scholarly scroll, but we have our AA meetings and our NA meetings, which are good for people, but it's hard for them to go sometimes. Sometimes that's why the online options are better. People don't feel comfortable going if they don't want to talk about their experience. If they were ever in a hospital, so if they were ever inpatient somewhere due to substance abuse, um, if they were ever in any different therapeutic communities, so they have like, the halfway houses or other programs where people can go stay to get treatment. And then we have our outpatient program, so just general therapy. One of the things that's also important to know as a mental health professional in working with substance abuse is the ABC model. And the ABC model is your antecedent, your beliefs, and the consequences. So your antecedent. So what is going to cause them to drink? Did they just lose their job and then they go into a frenzy to start drinking? And their belief, maybe if they stop drinking, like they're going to feel worse, like something bad is going to happen. And the consequence. So, what is the consequences of them over drinking or overusing a substance or drug? And then we have our screening tools and assessments, which we all need to know. We all need to do an assessment before we start treating someone with substance abuse so we can know all that past history. And without assessment, we can't write an essential treatment plan, along with screening tools, which will allow us to determine how severe it is. And if you ever have questions about any of this, or if you're working with someone with substance abuse, or if you're new to the field, or even if you're experienced and you have a question, a good line to call is the National Clinician Consultation Center at this number down here, 855-300-3595, and they will be able to answer your questions to help you determine what the best course of treatment may be, or to help you understand what the next steps are when you're working with someone for substance abuse. And now I'm going to pass it off to Jenna Staylor, who is going to talk about assessment.
Thank you, Natalie. Assessment of alcohol use disorder. Let's briefly address why a counselor might want to conduct an alcohol use disorder assessment. The overall goal of the assessment is to investigate a client's general circumstances and specific addiction related behaviors. The purpose of the assessment is that the counselor is working to collect information to develop a case conceptualization and potential diagnosis in order to build treatment goals. Next slide, please. This diagram indicates how a client might flow through the assessment process. If you start on the left, starting with referral or client presentation, the counselor might start to assess possible unhealthy use of alcohol for several reasons. Some counselors screen all clients for substance use issues. Um, The client may be referred by the courts due to legal issues. They may have been sent to counseling by concerned family or friends. They may be a self-referral reporting an unhealthy use of alcohol. Other clients may not report a problem with alcohol at all, but signs or indicators of possible alcohol misuse might become apparent in the personal history or in the initial clinical interview. Depending on the circumstances, oh, sorry, go back to that one. There you go, thank you. Depending on the circumstances, a brief assessment might provide the counselor with enough information for case conceptualization, or especially for clients with mild to moderate substance-related problems. If the counselor decides that more information is necessary due to the type and extent of the problem, a more in-depth assessment can be conducted. Basically, the counselor is working to collect as much information as necessary to develop targeted treatment plans. Also, if you'll notice the two-way arrow between the brief assessment and case conceptualization and treatment planning, I drew it that way because it's important to mention that a client's needs and circumstances should be reevaluated periodically throughout therapy. This continued reevaluation of therapeutic goals is particularly important for clients with alcohol issues, as there may unfortunately be many bumps on the road to recovery. Please, next slide. Okay. The assessment process. This slide is to quickly show the qualitative difference between a brief screening and a comprehensive evaluation. The brief screening might include one or two sources of information. The counselor may have access to a personal history, and they'll conduct a clinical interview. In addition, they might use a brief screening tool that can be either self-administered by the client or administered by the counselor. Whereas a comprehensive assessment is going to include multiple sources of information. You're gathering corroborating information on the client's history and their current circumstances. The multiple sources can include a personal history, a clinical interview, possibly interviews with family or friends, a physical examination, and more in-depth screening tools. Next slide, please. Okay, the clinical interview. The goal of the clinical interview is to collect as much information as you can and to set the tone for the therapeutic relationship. This is the counselor's opportunity to develop a functional partnership with the client. Now, the interview can be structured or unstructured. There are scripts or screening tools that counselors can use to collect specific information, or the counselor can simply use their own discussion style. In the clinical interview, the counselor is looking for signs of diagnostic criteria, including impaired control, social impairment, increased tolerance to alcohol or withdrawal, risky use, or an intense focus on an urge for alcohol. In addition, the counselor is looking to determine the function that alcohol has played in the client's life. What has it helped them do, or what has it helped them avoid? Next slide. Assessment tools. There are several assessment tools to investigate problem drinking patterns. The CAGE, I'm just going to go over a few here. The CAGE questionnaire is a quick 4-question test administered by a counselor. It's just screened yes or no, and the more yeses you get, the more likely it is that you are experiencing a problem drinking pattern. The TWEAK is a 5-item questionnaire initially developed to identify women who are at risk, during pregnancy. However, it can be used in non-pregnant people and women as well. It's said to be a very sensitive tool, good for using with all populations, especially women in general. The alcohol use disorders identification test. People call it the audit. It's a widely used 10-item screening tool developed by the World Health Organization to assess alcohol consumption, drinking behaviors, and alcohol-related problems. The MAST, 25-question tool used to help identify alcohol dependency. Questions on the MAST are related to risks associated with drinking patterns, neglect of responsibilities, and things like loss of control. And just the last thing that I wanted to mention about screening tools in general is obviously each one is going to have its own advantages and limitations. Ones that are quick and easy are going to just be a very broad overview of what is going on. And when you're choosing a screening tool, don't just consider what it is that you're using for, but review it a little bit. You should definitely review the literature on each of the screening tools that you're considering to check for how it was normed, its validity, and the reliability prior to use. Thank you. And now I would like to introduce Izzy, who's going to talk about diagnosis.
Thank you, Jenna. So as we've talked about the assessment, we might be kind of thinking to ourselves, like, what exactly is alcohol use disorder? So with alcohol use disorder, according to the DSM-5, there needs to be factors that involve withdrawal, tolerance, and craving. With withdrawal, it's when an individual drinks a significant amount of alcohol, and after that binge or so, after a certain time period, they will start to feel symptoms of feeling, sick, of feeling sorry, of the wanting to drink more. And then also there has to be tolerance involved. So that means the amount of alcohol the individual consumes, they have to gradually start to increase that amount in order to feel the effects of desired of the alcohol. And then finally, with craving, the individual has to experience a strong desire to continue drinking, which also could have to do with the effects of withdrawal. And then with population, who does this typically affect? Typically, the highest rates are in adults. They do differ from gender, age, social economic status, culture, and just demographic. So in reality, this can just affect the rates of alcohol use disorder can vary. And then going off to the next slide, we'll kind of talk about the criteria of alcohol use disorder. This is just taken from the DSM-5. Two of the following have to be present and over a 12-month span. So there's about 11 symptoms, and then they can range from mild to moderate and severe. So when thinking about diagnosing, we kind of also have to figure out where they fall under these codes as well. And then finally, after that, I will lead it to Michelle with treatments.
Thank you, Izzy. So this is a picture of the New York State Inebriate Asylum. We're talking a little bit about the history of treatments, and New York State was the first state to open an official medical treatment center. This was in 1964. And the difference between this and previous treatment methods was this one actually involved doctors. And it was a step up from what we were doing before, which were, for instance, homes for the fallen that were started in Boston, and cures that came out of the gold rush, such as the double chloride of gold cure for drunkenness. Next slide. Also about this time, we have Sigmund Freud, who was a doctor, and he was doing his own studies on a new miracle drug, cocaine. Not only did he promote using it for alcohol addictions, he also prescribed it for drug addictions, depression, indigestion, and much more. Beginning with the turn of the century, so around 1900, treatment plummeted as we came into war and depression. That's when we kind of regressed a little bit, and people who were considered drunks were put into drunk tanks, which is just another name for jails. But worse, they were put into insane asylums, where state law and federal law, I'm sorry, this actually makes me a little bit emotional, but they were allowed to be sterilized and human research was done on them. The next slide. So that brings us to today. With the formation of Alcoholics Anonymous in the 1930s, things started to turn around. So now we have We have much better treatments, much more research. We have many organizations that have dedicated themselves to coming up with good treatments. And this list has a few of the ones that are available for inpatient and residential interventions. So this is if the client is staying there overnight. And then next slide. These are outpatient interventions, and all of these on these slides are evidence-based treatments. These are ones that are probably the ones most commonly used in our practices that are private practices. Assigning a sponsor, positive repercussions of sobriety, discussing that. Also pinpointing activities that are substance-free. Bibliotherapy, there's lots of great research that we can give our clients to read if that's something they are interested in doing. Random substance screening. Also attendance at AA or NA, Alcoholics Anonymous or Narcotics Anonymous. And then of identifying triggers and also referrals for medication. Next slide. This is the part that's very exciting to me, is we've got great interventions in place right now, but there's also some really good treatments on the horizon. The integrative treatment plans, these are where SUDs are considered to be multifactorial. So if you have an alcohol addiction, instead of looking at it as treating an alcohol addiction, we look at the whole person and try to figure out why they got to where they are today. And then pull in other professionals that might be able to help them. The CAMs, these are evidence-based also, but they include some new therapies such as acupuncture, meditation, mindfulness, motivational enhancement, which seems to be really important because this is a very difficult process, rehabilitation. And so the clients need to be motivated. And then finally, we've got the ASAM 4th edition criteria. These are also wonderful things on the horizon. These are some of the ones that already have testing in place, although it's still new, so we need more testing. But community reintegration, getting these people back into the community and into their jobs. Trauma and cultural considerations, especially they're finding that addictions have a very strong connection to trauma, and particularly the early childhood trauma. Chronic medical care models. So for people that are doing this chronically, there's a different treatments that they're looking at. Stigma and client leadership, where we actually get the client to take leadership of this treatment, and also to help be a leader with others in some group kinds of therapy. So that's it for treatments, and I'm going to turn the time over to Faith Shore for research.
Thank you. Recent studies on alcohol disorders argue that further assessment of individual biological, demographic, clinical, and physiological factors can aid in predicting treatment success. You can go to the next slide. This research is based on the research domain criteria. It's a framework that's used to just further investigate mental disorders, to form better treatments that could potentially lead to cures to alcohol use disorders in the future. It is important to know that the research domain criteria is not intended to replace existing diagnostic structures, but it's just supposed to be used to help understand how life factors can influence mental illness. So the Addictions Neuroclinical Assessment, which is the ANA, it's based on the research domain criteria. It's supposed to challenge researchers to look beyond what an individual may be physically exhibiting or self-reporting. The assessment uses incentive salience, executive dysfunction, and negative emotionality to read the addiction cycle amongst individuals with alcohol use disorders. Incentive salience is identified as the point of the addiction cycle when an individual experiences reward or pleasure. So it could be maybe somebody that's had a hard week that is going to use drinking alcohol as a reward. The negative emotionality stage is assessing their negative experience with alcohol. So maybe a hangover, or just having stress after, either during their use of using alcohol or after. And then the executive dysfunction is experienced when an individual loses control. And so this could take place after they've consumed alcohol. So changes in their ability to problem solve, or changes in inhibition. You can go to the next slide. There are limitations to this research. And again, it's not supposed to be used to diagnose, but just a limitation to the research is a lack of current and relevant research. And also the lack of neuroscience diagnostic criteria for alcohol use disorder. Just because people that are using this research, it could influence them to overdiagnose or misdiagnose individuals. And that's all that I have. So I'm going to pass that over to Swara Patel.
Hi, everyone. Today we're going to be talking about some interesting or weird facts about alcohol use disorder. And I would just like to start by saying that these were just some of the ones that we found most prevalent regarding today's society and mindset regarding body image and just how we present ourselves to the world. So one of the first things that we found was that alcohol is actually shown to age you physically as well as your organs. So it's known that alcohol affects and damages your organ systems, and it can increase your mental health issues and everything as well. But what the spectrum of severity in AUD, the marked challenges to an individual's physical health, social functioning, and mental well-being can also accelerate the aging process by negatively affecting the organ systems. And in a study by Spencer and Hutchison, it was found that alcohol consumption can reduce anxiety while simultaneously activating stress hormones through the HPA system. And one of these stress hormones is cortisol. So cortisol is known to affect behavior, immunity, nervous responses, and metabolism, and the elevation of cortisol can result in premature or exaggerated aging. So this can also lead to weight gain, muscle weakness, which also affects an individual's overall appearance. The second thing that we found is that alcohol can cause different effects in men and women, and this is because of the biological differences between men and women. So because women have a lower body water rate ratio than men, they absorb alcohol at a much faster rate than men do. So this means that women can become intoxicated with much lower doses. I'm sorry, not at lower doses. At the same amount of doses, women can become more intoxicated than men can. In heavy alcohol use, even at low exposures in women, it was found to decrease fertility, while this is found as a possibility in men. On a similar note, women who are pregnant and using alcohol are associated with fetal deformities and other complications in the fetus, including fetal alcohol syndrome. Excuse me. Women with AUD were also found to experience more sexual dysfunctions, amenorrhea in ovulatory cycles, luteal phase dysfunction, and early menopause than women without AUD. In women, alcohol was also found to possibly have more negative effects on like their cognitive and motor effects. Excuse me. I'm so sorry. Can we like cut that part out? I don't know what just happened there. In women, alcohol was also found to possibly have more negative effects on their cognitive and motor functioning compared to men. Overhauls, there were a lot more lesser known facts about alcohol and alcohol use disorder, but these were found again to be the most prevalent regarding today's society. Hopefully with further research, we will be able to learn more and find out how this disorder continues to affect individuals in our society moving forward. Thank you for taking the time to sit with us and have a wonderful rest of your day.